differential diagnosis. I think this is the key point, because sometimes we have seen patients too late, and they were seen from a lot of specialized, like vascular surgeons, infectivologists, and or others, and they didn't recognize early this pathology. So it is very important to take as soon to make a correct diagnosis as soon as possible. And although general literature on Charcot disease, we have found that 44% of associated PAD. I don't know the possible answer. Maybe the possible explanation would be that how this patient developed peripheral arterial disease after the onset of Charcot disease, and in my opinion, it would be not so strange, because they are very complicated with a poor metabolic control and a lot of factors which can produce an endothelial damage. So I want to say that there are no significant differences in our experience, between stabilization treatments, and a conservative approach is effective in stopping the progression of the disease. I want to add, if the diagnosis was made earlier, in the majority of patients within 1 year, and the stability phase during the follow-up period appears to be protected and with low percentage of recurrences. And thank you for your attention.
Take this open from discussion. Up to the microphone, please. Very nice work from Pisa once again. I have one question, and you kind of addressed it. When we're talking about PAD in Charcot patients, we have to be very careful to specify, is this acute onset or is it chronic? And PAD certainly can develop after Charcot presents itself, but from the inference from your presentation, you were inferring these were all acute.
Yes.
So my question is, what is the operational definition of PAD? Edema, non-palpable pulses through the edema? What are objective measurements of PAD? This is retrospective also.
In our experience, we have assessed PAD with making the Windsor index, the ankle brachial index. So it was a simple operation, but we have assessed first of all with this instrument, and then with the imaging, with the Doppler ultrasound imaging. So, but I agree with you that we have to be careful when we deal with this PAD and Charcot disease, because I think we don't know, we don't have a clear explanation about that, and we have to differentiate all the patients, of course.
Maybe Czechoslovakia will give us that answer. Yes, sir.
I want to ask, did you think other medication rather than the stabilization of the atrocar or casting, such as making DIXA scan and see if the patients have osteoporosis or osteopenia, to give vitamin D or
TCC scan? What? Sorry?
DIXA scan.
Ah, yes, okay.
If the patient
I
has
think it's very
osteoporosis or
important
calcium or vitamin D or other medication.
Yes, I think this scan should be performed in every all these patients, because, and I think we will do that, because it's very important, in my opinion, to study bone metabolism and to correct, for example, vitamin D deficiencies, because most of our patients are nephropathic. So they present with low levels of vitamin D and increase of PTH secondary to the renal impairment. So I think it's very important to correct this. But I have no data about that. I don't know if correcting vitamin D deficiencies will prove obtain a benefit. I remind the experience of bisphosphonates and so I'm not so.
Thank you.
I have one question about the surgical interventions you did. You mentioned you did 4.2% amputations.
Yes.
5% surgical interventions. I think the 4.2% amputations not included in your surgical intervention, although I think the amputation was surgical intervention.
Of course. And this data could be sound low, because I think that conducting this kind of studies, retrospective studies, there are some limits. And for example, in Italy, there are only 3 centers performing surgical intervention of Charcot foot. So maybe the patients that we have analyzed are not the most complicated. So, but I think the key message should be one, that diagnosing Charcot foot in an early stage allows, in most of cases, a conservative treatment.
It would also be interesting how many patients you have referred to another center for surgical intervention, because
I don't have clear data about that, because it's very difficult to obtain this data.
The 4% amputation mirrors exactly, I think, Fabrin's paper from 2000. I think it's exactly the same. Anyway, grazie. Grazie, molto grazie.